Good to start, sir.
Okay. Good evening, all. Today we'll discuss about NEET SS 2023 recall like questions. It's not exact questions, it's the recall questions which are given by the previous students who have written the exam. So I'm Dr. Premnath, neurosurgery resident. The first question. So name the instrument shown in the figure. This is the instrument they have given in the question. Okay. So they are asking about name of this instrument. Okay. And what is this instrument is basically, this instrument is mainly used to create a burr hole, okay, for the purpose of creating a craniotomy. Okay, it's mainly used to create a burr hole. So this is your Hudson brace. Okay, the name of the instrument is Hudson brace. Okay, so what are the various instruments that commonly used in neurosurgery to know? What are the other instruments are given in the choices? Okay. So this is your Hudson brace. So the other name is called Hudson dura dissector. Commonly we call this Hudson. Okay. So the previous one is Hudson brace used to create burr hole. This is your Hudson. Okay. Hudson. The full name is Love Hudson dura dissector. Okay. This is mainly used to dissect the dura from the surrounding structures. Okay. So this is your dura dissector. The Hudson is your dura dissector. So it is a simple, this is a handle, and this is your dissecting blade. It is mainly used to dissect the dura from the surrounding structures. And this is your Rani's scalp clip. This clip is mainly used to prevent bleeding from the scalp issues while going for the surgery. Okay, mainly prevent the scalp bleeding. You have to apply this clip. This clip is called Rani's clip. The next instrument is Mayfield. Mayfield 3-pin head holder. Okay, this is mainly used in elective neurosurgeries where to hold the head in a correct position. Okay, this is Mayfield head holder. Okay, so these are the instruments, common instruments. So the previous question they asked is Hudson brace. So this is your Hudson, Love Hudson dura dissector. And this is your Rani's scalp clip. And this is your Mayfield 3-pin head holder. This is the number one question. Then number second. A 40-year-old male who is on low molecular weight heparin therapy undergone lumbar puncture, followed by the patient presented with the loss of continence, that is urinary continence or bowel continence, and paraparesis after 36 hours of the procedure. So what could be the most probable diagnosis for the condition? Okay, so the patient is on low molecular heparin therapy for some other purpose, maybe some DVT, okay, maybe due to DVT. He has undergone lumbar puncture. Okay, and after 36 hours of the lumbar puncture, he developed loss of continence and paraparesis. So what could be the most probable diagnosis? The options given are first subarachnoid hemorrhage. Okay, whether it is subarachnoid hemorrhage? No, it cannot be subarachnoid hemorrhage. The lumbar puncture can cause bleeding in the spinal fluid. It's called subarachnoid hemorrhage, but it will not present with the loss of continence or paraparesis. Okay, mostly it will come with the sensory symptoms. Okay, the option C, the root injury. If the lumbar puncture needle will cause a root injury, then the patient develop paraparesis or weakness in a single side, the unilateral side, whether the root is injured. Okay, so whether the cord contusion happens, if it is a cord contusion, the patient will develop complete paraplegia. Okay, and we have to know that the cord, usually the spinal cord ends at L1 level in the adult. Our lumbar puncture, the needle will be inserted at the level of L4, L5. Okay, so there is less possibility of the cord contusion for the patient. So this is not also a correct answer. And the correct answer will be your EDH. It's called spinal hematoma, spinal epidural hematoma. Okay, so that will cause your loss of continence and paraparesis. Correct answer will be the EDH. Okay, spinal extradural hematoma. The answer is your spinal extradural hematoma. So the same exact scenario that is given in the Saviston general chapters, the perioperative management chapter, 21st edition, page number 337, 338. What they have given is they are given for a theory for epidural catheter. Okay, in general, the epidural catheter should not be placed earlier than 24 hours after the treatment with the low molecular weight heparin. Okay, so you should not place the epidural catheter within 24 hours of the starting of the low molecular weight heparin. Okay, suppose you are giving epidural catheter previously, you should not start LMWH before 6 hours. Okay, an epidural catheter should not be removed earlier than 12 hours after the last dose of low molecular heparin. Okay, so the next scenario condition is the LMWH should not be restarted earlier than 2 hours after catheter removal. So these are the various scenarios, okay, that can be asked in the future questions. Okay, so a high index of suspicion of epidural hematoma must be maintained in patient undergoing neuroaxial blockades who have received or will receive low molecular heparin. So all patients involved in the care of patients receiving continual epidural analgesia need to be aware of the signs of epidural hematoma. So what are the signs? This is back pain, low extremity sensory and motor dysfunction, and bowel and bladder abnormalities. So reduce the risk. What I have to do? You have to place the needle. It's not done less than 10 to 12 hours after the last dose, and subsequent dose is delayed at least 2 hours, and the epidural catheter are withdrawn. It should be removed at least 12 hours, 10 to 12 hours after the last dose of low molecular heparin. Okay, these are the various scenarios that can be asked in the future questions. So our answer for the question is extradural hematoma. So what are the other possible MCQs that can be asked in future is the epidural catheter should not be placed earlier than 24 hours after the treatment is low molecular heparin. Okay, low molecular heparin should not be started before 6 hours after epidural catheter placement, and the epidural catheter should not be removed within 12 hours after the last dose of low molecular heparin. The low molecular heparin should not be restarted. Okay, earlier than 2 hours after catheter removal. The same only they are telling that to reduce the risk, the needle placement is not done less than 10 to 12 hours after the last dose, and subsequent dosing should be delayed at least 2 hours. Okay, and the epidural catheter are withdrawn at least 10 to 12 hours after the last dose of low molecular heparin. Next, the third question. A 65-year-old male. Okay, so old male, Mr. X, who is a known case of uncontrolled systemic hypertension for 10 years and not on regular medication, is presented to the casualty in a unconscious state and the intubated state. Okay, and the CT brain shows the following findings. So what is the next line of management? Okay, so what is the next line of management here? So there is the old age man who is having uncontrolled hypertension for 10 years and not on regular medication, comes to casualty in unconscious or intubated state. That means that he is having some hypertension induced hemorrhage in the brain. Okay, so the most common site for hypertension induced bleed in the brain is your Pontine hemorrhage. So the CT also shows the Pontine hemorrhage. Okay, and the Pontine hemorrhage happened, that is with the intraventricular extension that cause IVH. Okay, the Pontine hemorrhage is causing IVH. Because of the IVH, the ventricular absorption is hampered. Because of the ventricular, because of the CSF absorption is hampered, the patient developed hydrocephalus. So the patient having Pontine hemorrhage with the IVH. Because of the IVH, the patient developed hydrocephalus. So the patient comes in an unconscious and intubated state. Okay, that means his GCS is very poor. Okay, the general condition is very poor. So the prognosis of the patient is very low. Okay, so in this patient, what is the next line of management? Okay, so we should not leave the patient in a conservative form. So this conservative management is not an option. Okay, and this craniotomy and evacuation of ICH. Okay, this craniotomy and evacuation of ICH in this spontaneous hemorrhage. Okay, in this spontaneous hemorrhage is very risky. Okay, and the patient is also in very unconscious state. Okay, his general condition is also very poor. So in this state, we could not evacuate the ICH directly. Okay, if it is happening in the GC bleed, okay, if it is happening in the GC region, means we can go for a craniotomy evacuation if the general condition of the patient is good. Okay, so this is also not a good option. Okay. Then what about EVD? So the patient, immediately what we have to do is to relieve this IVH, we can reduce the ICP. Okay, the patient is, the main aim of the management is to reduce the ICP. How will you reduce the ICP means you have to reduce the CSF pressure inside by doing an EVD, okay, external ventricular drain. Okay, it is a temporizing procedure. It can be done in the bedside also. Okay, even in a it can be done very quickly. Okay, even in the bedside. Okay, external ventricular drain. Okay, so it will drain the hemorrhage in the ventricles. At the same time, it also drain the CSF, temporary diversion of the CSF. So it will reduce the ICP. Okay, it can be done. It can be a correct option. Okay, and the VP shunt could not be done in this patient. Why? Because VP shunt is a time-taking procedure, and this in the IVH setting, in the intraventricular hemorrhage, when we send the hemorrhagic CSF into the peritoneum, okay, the patient develops peritonitis. Okay, so this is not a very effective answer. So the effective treatment is initially we have to do the EVD to stabilize the patient to decrease the ICP. Okay, when the patient's consciousness is good, okay, we can go for the primary management. Okay, so at present, we have to go for external ventricular drain. The external ventricular drain is the correct option for this patient. So the answer is B, EVD. The reference is from Bailey and Love. So EVD. So external ventricular drain are an effective temporary measures to relieve hydrocephalus. Most commonly, they are inserted through a burgol at the Cocker's point. Okay, where is the Cocker's point? It is in the right of midline and is anterior to the coronal suture. Okay, this is the head. Okay, we are seeing the head from the back of the patient. Okay, we are seeing from the head to toe side. Okay, and this is our coronal suture. Okay, this is the midline. So midline. Okay, so we have to take the mid-pupillary point. Okay, mid-pupillary point. Okay, mid-pupillary point you have to take. Okay, that is right of the midline. This is right of the midline, and you have to take the mid-pupillary line and anterior to the coronal suture. This is anterior to the coronal suture. This is your point, coronal suture. This is your Cocker's point. Okay. So Cocker's point, we have to insert the EVD to the Cocker's point. Okay. Again, this is the head, it's the nose. Okay, this is your midline. Midline, this is your coronal suture. We have to insert the EVD to the Cocker's point. It is right to the midline and anterior to the coronal suture. It is perpendicular to the brain surface, so that the catheter tip rested the foramen of Monroe in the lateral ventricles. Okay, so everything will be the answer. They can ask us the EVD. It's a separate question also. All of the following are true statement except, like that also can be asked, because this is a very common procedure that done in the neurosurgical practice, in the emergency procedure. And intrathecal antibiotics may also be delivered through the EVD. And the lumbar drains are an alternative means of temporary CSF diversion. Okay. So this is a case of a pontine hemorrhage. The patient presented with the IVH with hydrocephalus. So immediate management, you have to go for EVD. The next The 18-year-old female presented to the neurosurgery OPD with a history of amenorrhea, galactorrhea with vision loss. On evaluation, the patient is found to have prolactinoma. Okay, the tumor of the pituitary gland, pituitary adenoma, that is prolactinoma, hormone secreting tumor, where the prolactin level of the patient is very high. Because of the prolactin level is high, the patient developed amenorrhea, galactorrhea. Because of the mass effect that is caused on the optic chiasma, the patient developed vision loss. So the MRI brain pituitary protocol shows the following findings. So this is your tumor that is compressing the optic chiasma. Okay, the optic chiasma superiorly it enhances it compresses the optic chiasma. Okay, the inferiorly it is from the sella. Laterally it enhances the internal carotid vessels. Okay, internal carotid vessels. Okay, and the cavernous sinus. Okay, so the question here is, the patient is planned for surgery. So what is the best approach for this patient? Okay, so it looks like a very big tumor. Okay, it looks like a very big tumor. It enhances the ICA, carotid sinus, and it's compressing the optic chiasma also. It's a very big tumor. What is the best approach for this patient? So usually in a small tumor, okay, within confined to the sella, we can go for transspinatal. It's the most common procedure is going for pituitary adenoma, but in this case it is not possible. Why? Because it is very large and it enhances the ICA, carotid sinus, and optic chiasma, compressing the optic chiasma. Okay, so it's not a correct option. So transectomal also is not a correct option. So we can go for transcranial. The transcranial approach is the correct operation, correct surgery, correct approach for this patient because of this very large tumor. Okay, and then in our followed transferal approach for the pituitary adenoma. Okay, so the option is transcranial. So answer C is a transcranial. So the reference is from Bailey and Love. So the compression of the optic chiasm with any evidence of visual compromise is the main indication for urgent surgical intervention. The surgical intervention is usually performed by transspinal approach through the nose using a microscope or endoscope. Sometimes the large tumors also require craniotomy. So this is so-called transcranial approach. After operation, the patients are at risk of CSF leak and pituitary insufficiency. That is post-operative complications. So here, the patient presented with the hormone secreting pituitary adenoma, very large tumor. The best approach for the patient is transcranial. Okay. The commonly using procedure is transspinatal for an average, a small size pituitary adenomas. Okay. Next, fifth question: the most common artery involved in the perioneurysm. Okay. So the most common artery involved in the perioneurysm. It is also again a controversial questions. Many books give the many answers. The references are very vague. Okay, but the following, the Bible of the general surgery, Love. Okay, it's giving answer is both AC and MCA. Okay, it's mainly the question is mainly taken from the picture. Okay, picture from the Bailey and Love. Okay, it shows that see this is your MCA and this is your ACA. The most common site of aneurysm is from the branch site. Okay. Okay. So IC, this is this ICA. So ICA giving the branch ACA, MCA. So at the junction only, the patient develops more percentage. That is 38% is between AC and MCA. Okay, and the next 36%. So ACOM aneurysm. The first, second. So the first option is still your branch point of AC and MCA, and the second best option is ACOM aneurysms. Okay. So the most common artery involved in bariatric aneurysm. This is a direct question from the Bailey. It's not ACA, not separate MCA. It contains both MCA and ACA. And the PCA is also not a good answer. So the correct answer is between ACA and the MCA. Antecerebral artery and the middle cerebral artery. So next come the 6th questions. This is also a general physiology-based questions. This is mainly taken from the neuro-ophthalmology. The gas paresis is seen. So the gas paresis is nothing but it's a gas palsy. And keep it as a gas palsy. Okay, where there is a weakness of extraocular muscle. Okay, so as we already know, mnemonic, everyone knows the mnemonic from the MBBS level. Okay, extraocular muscles are supplied by the mnemonic is LR6 SO4. Okay, the lateral rectus is by 6th cranial nerve, and the superior oblique is by 4th cranial nerve. Okay, restall by 3rd cranial nerve. So the options we given here is uncal herniation, occipital contusion, brain stem dysfunction, and cellular mass. So what should be the correct answer? So whenever happen uncal herniation, the uncal herniation will compress your 3rd nerve. Whenever the uncus is herniating, okay, uncus, it will compress your 3rd nerve. Here also we can get a gas palsy. Okay, but at the same time, the patient also having pupillary dysfunction also. Pupillary dysfunction also the patient will be having. Okay, in case of uncal herniation. Okay, there is a pupillary dilatation. In case of occipital contusion, the patient develop field defect. Okay, not the gas palsies. The patient develop field defect. Okay, and the cellular mass. When the cellular mass compresses the optic chiasma. Okay, the patient again develop bitemporal hemianopia. Okay, field defect. Okay, so whenever there is a brainstem dysfunction, then the patient develop gas paresis very effectively. Okay, so among the two options, uncal herniation, brainstem dysfunction, you can go for the brainstem dysfunction more frequently because the brainstem dysfunction will cause gas paresis very effectively. Okay, because all the LR6 SO4, okay, 6th, 4th, 3rd cranial all are affected. Okay, the patient develop very effective gas paresis. So brainstem dysfunction may be the good answer compared to the uncal herniation. Okay, so go for the brainstem dysfunction. So the reference is from Bailey and Love. It's mainly from the head injury chapter, trauma chapter. So the midbrain or brainstem dysfunction may produce gas paresis. Inability of the eye to look across beyond the midline. That is a definition for gas paresis. Why the patient is not able to look beyond the midline is because of the paresis of the weakness of the extraocular muscles. And when the brainstem dysfunction happens, the patient also develop disconjugate gaze. That is inability of the eyes to work together. Okay, and the patient also having roving eye movements. Okay, the eye will rose. Okay, and then you have to inspect the conjunctiva and the cornea and the retina using an ophthalmoscope and looking for hypemia, blood in the antechamber of the eye, a papilledema, retinal detachment. These are the ophthal findings what will happen in the trauma patients. Okay, you have to look for the eye. This is eye findings that are usually happening in the head injury patients. Okay, so here the main dictum is the brainstem or midbrain dysfunction will cause gas paresis. Okay, and then disconjugate gaze and roving eye movements. The next question. So all of the following are the cutaneous markers of spinal dysraphism. Okay, the spinal dysraphism is the collective term of the spinal cord maldevelopment. Okay, so what is the external cutaneous markers? Okay, the dermal sinus will happen. Yes, dermal sinus will be there. Tuft of hair will be present. On the second lesion, yes, tuft of hair will be present. And capillary hemangioma is there. Yes, capillary hemangioma is there. So your asclepic macules will not be there. Okay, so where the asclepic macules is usually present in the case of tuberous sclerosis. It's not present in the spinal dysraphism. It's a direct question that can be asked from the Bailey. Okay. So Semester. So Semester 72nd edition, page 1910. It's also occult spinal dysraphism often manifests cutaneously in the lumbosacral areas in the form of hemangioma, hair tuft, dermal sinus tracts, and the lipomatous masses are frequently seen. So this condition is frequently associated with the tethered cord syndrome. So what is tethered cord syndrome? This cord syndrome is clinically manifested as back and leg pain, gait difficulties, weakness, orthopedic deformity, body dysfunction, and sexual dysfunction. These are the various presentations of the tethered cord syndrome. The cutaneous marker is one is hemangiomas, hair tufts, dermal sinus tracts, and lipomatous masses. So rash-free macules is mainly present in tuberous sclerosis. So these were cutaneous hemangioma, okay, lumbar cutaneous meningioma. Okay, then patient seen the patient with the spinal dysraphism. So this patient is having occult spina bifida. Okay, spina bifida occult. So next, the direct numerical question that asked from the Bailey, semester, which is what is a cerebral perfusion blood flow rate? Okay, so this is a direct question. The cerebral perfusion blood flow rate is 30 to 100 ml per 100 gram of brain tissue per minute. Okay, this is a normal cerebral perfusion blood flow rate. Okay, so again given the 32nd edition. So the principle is that the cerebral blood flow normally varies over a wide range of 30 to 100 ml per 100 gram of brain tissue per minute, and it mainly depends on metabolic demand from the neuronal activity with a particular area of the brain. Okay. So what are the other MCQs that can be asked in future is, these are some important numericals that you have to remember. Okay. The spinal fluid, that is CSF, is produced at a rate of 15 to 20 ml per hour by the choroid flexus of the ventricle. Just make a note. Okay. You don't need to remember all the numericals in the neurosurgery. That's some common numericals in the neurosurgery. One is for cerebral blood flow is 30 to 100 ml per 100 gram of tissue, and this is for CSF rate is 15 to 20 ml per hour. Okay. And what other conditions? What are the other parameters to maintain in head injury patients in a Neuro-ICU? Okay, mainly you have to remember these three things. Okay, MAP, ICP, and CPP. So the mean arterial pressure should be maintained between 80 to 90, and the intracranial pressure should be maintained is less than 20. The cerebral pressure should be maintained, should be more than 60. Okay, these are three numerical you should remember. At least you remember MAP and ICP. Okay, because what is the formula for CPP? It's equal to MAP minus ICP. Okay, so if you take the higher values of MAP and INT and the ICP, 20 means gave us 70. You can derive it to the CPP is equal to 70. That means indirectly means that it's more than 60. Okay, so cerebral blood flow rate is 30 to 100 ml per 100 gram of brain tissue, and the spinal fluid is produced at a rate of 15 to 20 ml per hour. Okay, and the mean arterial pressure is equal to 80 to 90 millimeter of mercury, and the ICP is less than 20 millimeter of mercury, and the cerebral perfusion pressure should be maintained more than 60 millimeter of mercury. Okay. Next question: a 54-year-old male underwent RTA and he fractured a head injury. So immediately, note the term, immediately after that, the patient having history of watery discharge from the nose after injury and is salty in taste. Okay. So what is the next line of management? So immediately after this, the patient developed water discharge means, water discharge from the nose means everyone knows that it's a case of CSF rhinorrhea. And what we have to do immediately? That is the answer. Okay. You have to go for higher antibiotics? No. No need for higher antibiotics immediately. Okay. And immediate surgery to prevent the meningitis? No. That is also not needed. We could not go for the very high surgery to prevent it from meningitis. So acetazolamide review after 3 weeks. That is also not a correct option. Okay. We should not give directly the drugs in the at the day of surgery, at the day of the injury itself. We will not give the acetazolamide. And the observation will be the correct answer. Okay. So initially we have to observe the patient. Okay, most of the CSF rhinorrhea will settle spontaneously on observation. Okay, that is a main dictum. Okay, observation is mainly needed. Okay, so this reference is mainly taken from the ENT chapter. Okay, nose chapter of the Bayesian law. It's given that the dural tears and brain injuries either open or closed are then at a risk of sinonasal ascending infection, which may progress to the meningitis and the brain abscess. Sorry for the noise. So dural tears lead to the meningitis and brain abscess. The CSF rhinorrhea is a certain signs of dural tear. The CSF rhinorrhea will be confirmed by collecting a sample of the fluid and sending for beta to transferrin assay. Okay, beta to transferrin assay will the diagnostic for the CSF rhinorrhea, which is the very costly investigation not available in all institutions. Okay. Okay. And the bony defect in the anterior skull base following trauma can be identified on high resolution CT. The CSF leak will often settle with the conservative management. But if persistent, it can be repaired endoscopically. Okay. So these are other options. These higher antibiotics, acetazolamide, that can be given as a next step. The first step is usually observation as for theoretical purpose. But in clinical practice, we are not doing observation. We will start with antibiotics and acetazolamide. But for MCQ purpose, it's always observation. It's what the book says. Okay, the human textbook of neurosurgery is also saying that most of the cases will settle on with observation. The CSF leak is still persistent. Then will we go for next line of management, medical management. That is antibiotic, acetazolamide. Even if it is also persistent, we'll go for the lumbar puncture. Okay, and continuous lumbar drainage. Okay. Even if it is persistent, even the CSF leak is persistent, then we'll do a cystonotomy. Cystonotomy will do cystonogram. Okay, CT cystonogram will identify the defect and will repair the defect. So these are the protocol for CSF rhinorrhea. It starts with the observation. It's still persistent, we go for medical management. Still persistent, we can go for a lumbar puncture, continuous lumbar drainage. If still persist only, we can go for repair. Okay, we can go for surgical repair of the defect. Next question, which of the following genetic abnormalities is particular to pilocytic astrocytoma? Okay, the pilocytic astrocytoma. So these are very difficult questions only. Hello, sir. Yes, sir. Sir, car. Sir, right. Okay. Which of the following? Sorry for the students. Which of the final question is which of the following genetic abnormality is particular to the pilocytic astrocytoma? Okay. The options are STK11 mutation, ATRX loss, APC gene, and KRAS gene. Okay. Among these, the answer is your ATRX loss. Okay. ATRX loss will be the answer. Okay. So where it is mainly taken from is the reference for this question is Bailey also we can give, because the Bailey they can give a flow chart of histology of the main brain tumors like astrocytoma, oligoastrocytoma, oligodendroglioma, or glioblastoma. Okay. So in these patients, there are various type of mutations that happen. In the astrocytoma, the various mutations available are ATRX loss, T53 mutation, and 1p19q co-deletions. These are the various mutation types available for the astrocytoma. So among the options given here, so the STK11 mutation is not come for this. The glioma tumors will not come for STK11 mutation, and the APC mutation is only for familial adenomatous polyposis. Okay, and the KRAS mutation is also not having any astrocytomas tumor. So by ruling out the main the pilocytic astrocytoma will come under ATRX loss. Okay. So in analyzing the previous year topics, the more topic to focus more on, have to focus for on instruments, basic instruments, and the intracranial dynamics. Okay, that is a ICP chapter. Okay, how to reduce ICP. Okay, so what are the various laws behind the ICPs, and what are the numericals? That is very more focused topic. Next on the spine's injury. So once injury of spine can be asked, and head injury they ask two questions mainly from the CSF rhinorrhea and one general question. Okay, from the head injury, that is gas paresis. Okay, and the vascular topics like ICH and SAH. Okay, to be focused more. And they ask one question from the pediatric neurosurgery, spinal dysraphism. From the neuro-oncology, they ask two questions. One is pituitary adenoma, and another one is the pilocytic astrocytoma. So these are some areas to be focused more. Okay. Thank you, and all the best for your exam. Thank you.
Sir, really sorry.
Is my voice audible now?
Yes, sir. Proceed, sir.
Yeah. Sorry. So, welcome to this previous year's discussion. I am Dr. Mithun. I will be discussing the endocrine and breast surgery questions predominantly. So, let's proceed with the questions. Last year, actually, a lot of questions had come from endocrine as well as breast. I think some of the breast questions I have put it again in this discussion. Maybe some overlap with the discussion from surgical oncology. Bear with me for that. But I think a lot of questions last year have been asked from endocrine surgery. So again, endocrine surgery is a high yield topic when it comes to the NEET super specialty surgery paper. So we'll be looking at some of last year's endocrine surgery questions. Let's discuss the options and some explanations behind it. So let's go to the questions without wasting much more time. Okay. I think this question has been discussed under surgical oncology as well. So let's just relook at this question. So this is a clinical scenario, and these kind of questions are very common. You will get clinical scenario with imaging questions as well. So this is a image of a mammogram that is given. This is a female patient with a 4 into 4 centimeter breast lump and an ipsilateral axillary lymph node which is measuring 1.5 centimeter. FNA has been done from that ipsilateral axillary lymph node, and that FNAC is negative. And this patient on imaging has found out to have no evidence of distant metastasis. So you have this picture of this mammogram that is given here. Again, they may describe the mammogram. Sometimes they may just give you the picture. You have to figure out what is there, what is the finding that is there in the mammogram. If you can notice here, there are these multiple areas of diffuse punctate small micro calcification, and these calcifications are actually, if you notice, they are not uniform. First of all, you must differentiate. Any micro calcification is suspicious as compared to a macro calcification. A macro calcification is something that is what is known as chunky calcification that is visible on the mammogram. And in this scenario, you can see how there is micro calcification that is involving not just one particular quadrant, but this is involving the diffuse microcalcification, which is involving almost multiple quadrants of the breast. So this is a multicentric disease. So what is the difference between multicentric and multifocal? Very important. Multifocal is involvement of multifocal is essentially involvement of single quadrant multiple lesions, whereas multicentric is involvement of different quadrants in the breast. So they have asked us for management for this patient. Now biopsy from this breast lump is reported as invasive ductal carcinoma. So these are the options that have been given. So let us look at first what is the clinical stage for this patient. So important to start with the clinical stage of this patient. So this is a 4 into 4 centimeter lump. So the maximum dimension is 4 centimeter. So this belongs to a T2 disease. Now, if we go through TNM classification, again, up to 2 centimeters is T1, up to 5 centimeters, that is including 5 centimeters is T2, and anything more than 5 centimeters will become T3, unless it involves the skin or it involves the chest wall or it is an inflammatory carcinoma. So if it involves the skin, if it involves the chest wall, or it has an inflammatory picture, then these three clinical scenarios, they will be T4 disease. So again, we know involvement of chest wall is T4A, involvement of the skin becomes T4B, T4C actually involvement of both the skin as well as the chest wall, and T4D is a inflammatory carcinoma. So when do we call something as inflammatory carcinoma? Inflammatory carcinoma is when at least 1/3 of the breast is involved and there are signs of inflammation, and usually the duration of illness is a protracted less than 6 months duration of illness involving more than 1/3 of the breast. So that is inflammatory carcinoma. So remember, to 2 centimeter. So including 2 centimeter is T1, up to 5 centimeter, including 5 centimeter is T2, more than 5 centimeters T3, and T4 diseases, these three things, that is skin involvement, chest wall, and inflammatory carcinoma. So this here is a 4 centimeter tumor. There is no information given here about the skin involvement or chest wall involvement. So we are assuming that this is T4B. Now, ipsilateral axial lymph node is there, measuring about 1.5 centimeters. However, FNA is negative. So this kind of patient in whom we have a lymph node that is palpable, but we have done an FNA and it is negative, we can label this patient as N0 disease. So again, there is no distant metastasis. So this patient becomes T2N0M0. Now T2M0 N0M0 falls under a early breast cancer category. So this is a early breast cancer. Now, if this patient had bulky nodal disease, or it was a large T3 tumor, or basically anything beyond T3N1M0, or if it was definitely T4B disease, then these patients would go into a locally advanced breast cancer. So now, when we look at early breast cancer, the appropriate management for early breast cancer is usually breast conservation surgery. So now, whenever we talk about surgery for the breast, it usually is surgery for the primary and surgery for the axillary lymph node. So this is how we classify surgical management. So again, surgery for the primary in an early breast cancer, unless and until there are some contraindications, I will be showing you a slide on that. Most appropriate management for an early breast cancer is going to be breast conservation surgery. Now, in this patient, what would be the most appropriate management? So the catch here in this clinical scenario is this presence of extensive diffuse microcalcification involving more than 1 quadrant of the breast. So that is the real catch here. So if we look at management of this particular clinical scenario, definitely BCS is a contraindication in this clinical scenario. So definitely option A is ruled out. So you cannot do BCS in this patient because of the presence of diffuse microcalcifications. Now let us look at the other option. So again, this option is also probably you can rule out because of this. Now what about neoadjuvant chemotherapy? So what about this? So usually there are certain indications to do neoadjuvant chemotherapy. We give neoadjuvant chemotherapy usually definitely in locally advanced breast cancer, or sometimes when there is a subtype known as large operable breast cancer. So you have a T3 tumor, which is very large, usually let's say 7 centimeters, 8 centimeters. You will not be able to give adequate margin and achieve skin closure. In those patients, again, it is better to do neoadjuvant chemotherapy. But however, in this patient, T2N0M0 early breast cancer, you can avoid a neoadjuvant chemotherapy. Now, in early breast cancer as well, there are certain scenarios, certain aggressive subtypes where you can give neoadjuvant chemotherapy. So usually patients who are triple negative breast cancer, or if they are HER2 overexpressed breast cancers, in this scenario, usually even in early breast cancer, unless they are very small tumors, even in early breast cancer, you would prefer to give neoadjuvant chemotherapy. Now, in this clinical scenario, they have not given us the ERPR HER2 new receptor status. They have not given us the Ki67. So that information is not available to make that decision. So in that scenario, for a patient like this who is node negative, so again, node positive disease is a relative indication to give neoadjuvant chemotherapy. Some people, even in T2N1 disease, do give neoadjuvant chemotherapy because node positivity is counted as an aggressive factor. So T2N0M0 node negative small tumor, you can definitely don't require neoadjuvant chemotherapy unless and until it is an aggressive subtype such as a triple negative breast cancer or a HER2 overexpressed breast cancer. So in this clinical scenario, I would go with the answer of modified radical mastectomy. So let's look at a few points again. As I mentioned, remember why we are saying that conservation is not possible here. It is because diffuse microcalcification. So this is usually microcalcification signifies a pre-malignant change, which is ductal carcinoma in situ. So now why does DCIS have microcalcification? that is basically dystrophic microcalcification. There is a proliferation of cells. Initially, you have a papillary growth that forms a cribriform pattern, and as the proliferation increases and increases, the cribriform pattern becomes a solid pattern, and finally the ductal cells outgrow its blood supply. So basically, they initially they have a cribriform sieve-like pattern, and as the cells proliferate more and more, they completely fill the ductule and they block the ductule. So that is known as a solid appearance. And eventually, once they outgrow their blood supply, they are going to develop areas of there are cells. There are also areas of necrosis. So this is known as a comido appearance. So comido appearance or comido necrosis, we just put that down. So comido appearance or a comido necrosis is a poor prognostic factor. This actually signifies a high grade DCIS. Right. So these areas of necrosis undergo dystrophic calcification, and that is why they appear as microcalcifications. So microcalcifications in a mammogram. So this is a very important concept to understand. So basically mammogram, that is why we use mammogram for screening. Mammogram is a very sensitive tool. It helps us pick up these microcalcifications at an early stage, and you may be able to pick up more amount of DCIs. In fact, screening mammograms, once we started doing screening mammograms, the amount of DCIs that we have been diagnosing has increased exponentially as compared to invasive ductal carcinomas that present with even more advanced signs such as architectural distortion, skin involvement, etc. So, an early sign in mammogram is microcalcification. Again, this is also important thing. These are all these points can be asked as potential MCQs. Now, remember, when we have DCIs, again, there are multiple options that we have for management. All depends on the extent of the DCIs that we have, the histological grade, and other present, and whether there is a risk of microinvasion, etc. Of course, patient preference also is an important factor. So remember, again, very important point: multicentric tumors. Now, multifocal tumors are a relative contraindication for BCS. However, patients who have two tumors in the same quadrant, you can still do a breast conservation surgery. You can do a quadrantectomy, and following that, there are various techniques. You can use level 1 oncoplasty, you can use level 2 oncoplasty, you can use either a perforator flap, local flap, or you can use pedicle based flap like an LD also. So a lot of options that have opened up treatment or a lot of options that have opened up BCS even for a multifocal tumor. However, multicentric tumor, again, these are usually best managed by mastectomy, because it's usually the whole point of doing a breast conservation surgery is to give good cosmesis, and usually that you cannot achieve when you have a multicentric tumor involving more than two quadrants. So again, this patient, as I mentioned, T2N0 disease, because we don't have receptor status, there is no indication for neoadjuvant chemotherapy in this patient. So we can do upfront modified radical mastectomy. Now let's look at certain indications for BCS. So again, remember, first most important thing is patient wants BCS. You have a relatively smaller tumor. So then T3 also we can do a BCS. T3 is not contraindicated to do a BCS, but preferably in a T1, T2 lesion, which is less than 5 centimeter. Again, it is easier to conserve the breast. Very important thing is the tumor to breast volume ratio. So a patient who has a large tumor in a small breast is not ideal for breast conservation. So you have a large tumor, but the breast volume is small. At the same time, if you have a smaller tumor, but the breast volume is larger, then your cosmesis will be more acceptable. So that is an important indication for BCIS. Again, patients, you have to be able to give breast conservation therapy. Involves breast conservation therapy is basically BCS, which is wide local excision of the primary. Along with this, you always have to give radiotherapy. So radiotherapy, that is because we are leaving behind the rest of the breast, unlike a modified radical mastectomy where we are removing all the breast tissue. Now again, radiotherapy, you'll have to do what is known as whole breast radiotherapy. So you give radiation to the entire breast. At the same time, usually we also give something known as a tumor boost. So we give about 10 to 12 grays of radiation to the tumor bed. So usually after doing a wide local excision, we mark the cavity with the placement of clips. and so that the radiotherapists can plan their radiotherapy and they can give a tumor boost to the tumor bed. So basically, because most of the tumor recurrences occur at the site of the tumor bed, so that is why tumor boost is very important in preventing recurrence. So this is important. So usually we do a whole breast radiation along with tumor boost. So in patients who undergo BCS, mandatorily all of them have to receive radiation therapy. So in patients who are unable to give radiotherapy either because of lack of availability or there is some contraindication. So a lot of contraindications. There's a very important table in Sabiston. I have not put it down here. You can go back and refer the table in Sabiston. A lot of contraindications that are there for radiation therapy, like for example, previous radiation therapy that has been received, presence of collagen vascular diseases. So a lot of contraindications are there. So please look at that table in Sabiston regarding contraindication for radiotherapy in breast cancer. So again, patients who have N0 to N1 axillary nodes, again, ideal to do a breast conservation surgery. Anybody who has more nodal disease, N2 disease and further, better to downstage them using neoadjuvant chemotherapy, and then you can still do BCS, but again, N0, N1 is ideal. And of course, you should have a adequate breast volume to allow proper radiation dose distribution. Now, what are the contraindications? Again, important. Patients who are pregnant, these patients you cannot give radiotherapy because radiotherapy is contraindicated. You should not do BCS for these patients. Patients who have diffuse, suspicious or malignant appearing microcalculi. This is what was the case scenario that was given to us. So patients who have diffuse microcalcifications, you should not do conservation surgery. And again, if you have widespread disease, for example, you have multicentric disease, you're not able to give a good cosmetic result with a single incision, then again better to avoid BCS. And of course, patients who tend to have diffusely positive pathological margins, again better not to do a BCS. Relative contraindications, of course, you give these are basically contraindications to radiotherapy itself. So previous radiation patient is already received to the chest wall. There is connective tissue disease for the skin, so collagen vascular disease, scleroderma, lupus. Again, tumors more than 5 centimeters. This is a relative contraindication, not an absolute contraindication. You can still conserve the breast. And of course, patients, if they have high likelihood of positive pathological margins. Who would you do a mastectomy for? Again, some patients will not want to do a conservation. They would prefer to have a mastectomy. So in those patients, yes. If you have multicentric tumor, you're not able to achieve good cosmetic result, then again do a mastectomy. You have positive margins, again you're unable to get a negative margin because of the size of the tumor or other factors, then better to do a mastectomy for these patients. Diffuse microcalcifications, definitely do a mastectomy. Patient not able to follow up regularly, and of course tumor volume ratio, unfavorable tumor volume ratio. You have a large tumor with a relatively smaller breast, then better to do a mastectomy. And multicentric tumors, again, this is something we discussed, and of course, contraindications to radiotherapy. This is a very straightforward question, just that you need to understand this scenario would, let me just tell you, this scenario would have changed if you are given ERPR status. So same scenario if you are given with a patient who is triple negative breast cancer, even though it is early breast cancer, triple negative, T2N0, I would then, that scenario, I would go ahead with neoadjuvant chemotherapy. And then finally for surgery, I would still do a modified radical mastectomy. So if this was a triple negative patient, or if it was a HER2 overexpressed patient, then we would do neoadjuvant chemotherapy followed by MRM. But because that information is not available here, we should go with upfront modified radical mastectomy. I think this is pretty straightforward and should be quite clear. Okay. So now let's go to the next question. So this is a question on skin sparing mastectomy. So what is the risk of recurrence in skin sparing mastectomy? So less than, so here again they've given T1 or T2 disease, and they've asked about the risk of recurrence in skin sparing mastectomy. So remember, when we do, there is something called a modified radical mastectomy, and there are other types of mastectomy which are more conservative mastectomy. So conservative mastectomy is basically, again, you have nipple sparing mastectomy, and in this you also have a skin sparing mastectomy. So we'll just be looking at some points about nipple sparing and skin sparing mastectomy. So let's look at the options here. So they're given less than 50% for T1, more than 50% for T2, no recurrence in T1, T2, or less than 25% recurrence in T1, T2. Now remember, even though it is considered to be a conservative, more conservative type of mastectomy. However, it does have a smaller risk of recurrence. However, the risk of recurrence is very low. So when do we use this kind of conservative skin sparing mastectomy? Usually we use it in what is known as risk reducing mastectomies. So risk reducing mastectomies are basically procedures that are done for high risk patients who have a more than 25% chance of hereditary breast carcinoma. Typically, like we have a BRCA mutation, so a BRCA1 carrier or a BRCA2 carrier. These kind of patients who have a high risk, more than 25% risk of developing the breast cancer, we offer them a risk reducing mastectomy. So that is where we offer these patients with conservative options. So nipple sparing or a skin sparing mastectomy. So the answer here is the risk is low. It is not 0%. There is definitely some percentage of risk, but the risk is definitely low, less than 25%. So let's look at some data about nipple sparing and skin sparing mastectomy. So basically, what we do in a skin sparing mastectomy is that we remove the breast tissue. Of course, in a skin sparing mastectomy, what we do is the nipple areola complex is removed. So you can look at this picture here. The whole point of a skin sparing mastectomy is you basically preserve the skin envelope. So the point of doing a skin sparing mastectomy is to preserve the skin envelope. Now, what about the nipple sparing mastectomy? So, nipple sparing mastectomy, we try to preserve the skin envelope along with the nipple areola complex. So, that is the difference between a skin sparing mastectomy and nipple sparing mastectomy. So, you can see this picture that is given here. This is a skin sparing mastectomy. You can see how this is like a round block excision. So, this is a circumareolar incision that is given here, and there's another concentric circle that is taken, and flaps are developed in the same plane that we do like a mastectomy, like a regular MRM, and the entire breast tissue is taken out from the chest wall through this incision, and finally this is the specimen that's excised. You can see here how we have the superior flap and the inferior flap. Both these flaps, the skin is not sacrificed, so here the skin is preserved. Now, recurrence rate is very low. As I told you, it is not 0%. Definitely, there is about up to 8% of recurrence, and usually this is indicated up to T3 malignancies. However, when you look at long-term recurrence rates compared with MRM, they are good. That is why skin sparing mastectomy and nipple sparing mastectomies are offered to patients for risk reduction. So, in these patients, we can remove all the breast tissue, and usually some of these patients will prefer to have an implant. So you can place a silicone implant usually in the subpectoral region, and you can cover the implant either with the patient's own dermis. You can do a dermal sling and cover the exposed part of the implant, or you can even use some bit of LD muscle or an LD flap to give some muscle cover to cover the lateral part of the implant that may be exposed. The medial part of the implant entirely goes under the pectoralis major muscle, or between the interpectoral plane. That's why we put most of the implant. So let's look at some indications for skin sparing. Again, extensive DCIS. The first patient that we saw, we can do a skin sparing mastectomy if it is not close to the skin. So definitely that is an indication to do a skin sparing mastectomy, and then you can do a implant also for that patient. Again, IDCs you want to do for infiltrating or invasive ductal carcinoma, then early stage. So stage 1 or stage 2. In stage 3, again, very selective. So nodal disease, T3N1 and beyond, very select cases you can do a skin sparing mastectomy. More easier to do skin sparing mastectomy with smaller tumors, stage 1, stage 2. And again, you should not have any disease. So basically, if you have done a nipple sparing mastectomy, however, the retroviral tissue below the nipple sparing mastectomy is positive for malignancy, then you definitely have to take out the nipple areola complex. So in that scenario also, you'll have to do a skin sparing mastectomy. Now, what about nipple sparing mastectomy? Again, similar scenario, you have a large or extensive DCIS, or you have multicentric disease. And important thing to remember here is the distance from the nipple to the tumor has to be at least 2 centimeters. So you have to have 2 centimeter distance between the primary and the nipple areolar complex, and there should be no nipple edema, there should be no involvement of the skin. So that is very important. Of course, you can do it in IDC also, not only in DCIS. In patients who have multicentric disease, you're doing a BCIS, you're not able to get a good result, then again, these patients you can do nipple sparing mastectomy. BRCA carriers, we already mentioned this. Patients who cannot undergo BCS because of bad tumor volume ratio or unfavorable tumor volume ratio, then again, that's basically a small breast or a medium breast or a large tumor, and location of the tumor is unfavorable, then again, you can do a mastectomy with sparing the nipple, and then you may put an implant. So contraindications for skin sparing mastectomy, very important. You cannot do a skin sparing mastectomy when there is evidence of inflammatory carcinoma. T4B disease involvement of the skin again is a contraindication for skin sparing mastectomy, because you are leaving behind the skin envelope and there is a higher risk of recurrence in those patients. Locally advanced carcinomas, not only T4B, also heavy nodal burden, relatively contraindicated. Smoking is also relative contraindication. Again, that is because the quality of the skin envelope that we are going to preserve will not be good in patients who are chronic smokers. So what about nipple sparing mastectomy? Again, inflammatory carcinoma, skin involvement, locally advanced disease, you would avoid doing a nipple sparing mastectomy. It is relatively contraindicated in patients who had previous radiation therapy, smokers, these kind of patients who have comorbidities like diabetes, again, because the chance of nipple necrosis after doing a nipple sparing mastectomy is higher. Patients with large ptotic breasts, again, for the same reason. And of course, if you've previously had any periareolar surgery, you've had a subareolar abscess or a periareolar abscess, you've had microdocectomy for some other benign condition, these patients, there is going to be scarring in the below the nipple areolar complex. So raising a plane under the nipple areolar complex for a nipple sparing mastectomy is going to be difficult. So these are some of the contraindications for doing a nipple sparing mastectomy. Okay, so this is a slightly difficult question, I would say, because it's kind of difficult to figure out what really the sign is. So I'm presuming the question was like this. So they identify the sign shown here. So the multiple options that were given is Stellwag sign, BBS sign, Geoffroy sign, or Von Graf sign. So this is basically a very important question. So you must know these eponymous thyroid eye sign. Now remember, it is not practical or it is not possible to remember. There are some 25 to 27 named thyroid eye signs. Not important to know that, but at the MCH entrance exam level, you should know what is given in DAS. At least those 5 eye signs and something little bit about the eye signs, you should be able to identify them. So if you look at here, this is, so let's look at all these eye signs. So this is actually a what is known as Stellwag sign. Okay, so Stellwag, S for staring. This is the most common thyroid eye sign. So the most common thyroid eye sign that is found in hyperthyroidism or Graves' disease is a Stellwag sign, or generally in hyperthyroidism, not particularly Graves' disease. So in hyperthyroidism, the most common eye sign, very important MCQ, the most common, sorry, I think just a minute. Yeah. So the most common eye sign in hyperthyroid disorders is a Stellwag sign. So let us just go through the eye signs in short, in brief. Now remember, the staring look actually comes in hyperthyroid disorders because of infrequent blinking. Now, if we look at, I'm just going to tell you a small classification. So if you look at thyroid eye signs itself, you can broadly classify them into 2 different categories. So one is basically, there is something known as infiltrative eye signs. Infiltrative eye signs, and there are other types of eye signs are increased because of increased sympathetic activity. So this is how you can broadly classify thyroid eye signs. Now, when you say infiltrative eye signs, these are very specific for diseases such as Graves' disease. Now, when you talk about increased sympathetic activity, these can be found both in Graves' disease as well as this entity known as thyroiditis, right? Infiltrative eye disease is basically when there is infiltration of the periorbital soft tissues, especially the retroorbital fat, and if there is involvement of the extraocular muscle. So that is very specific for Graves' disease. For example, if you look at this sign, Mebius sign is basically the loss of convergence. So basically, there is lateral rectus, there is medial rectus palsy, there is loss of convergence. So this occurs because of infiltration of the retroorbital tissues and the extraorbital muscle. So Mebius sign is an infiltrative eye sign. This is very specific for Graves' disease. Now, most of the other signs occur because of increased sympathetic activity. So why do we get Stellwack sign and Dalrymple sign? Again, this is because of increased activity, increased constriction of the smooth muscle. Remember, sympathetic overdrive can cause increased smooth muscle constriction. So increased smooth muscle constriction can cause these two signs. So why do we get a Dalrymple sign? The Dalrymple sign is basically lid retraction. So basically, when the on the downward gaze, the upper lid is slow to close as compared to the gaze. So that is why you are able to see the upper sclera. Now, Von Graffi is also Von Graffi is a lid lag, whereas Dalrymple is a lid retraction. So in a normal patient, if I was to draw the eye, you will not be able to see the upper or the lower sclera. However, in a patient with a lid lag or a Dalrymple sign, usually the upper lid is retracted upward. Again, this is because of increased smooth muscle contraction, that is of the levator palpebrae superioris. So the increased levator palpebrae superioris is going to lift the upper eyelid up. So you are able to visualize the upper sclera here. Now, Geoffroy sign is basically when the patient does upward gaze, there is loss of forehead wrinkling. Again, here, this is also because of increased contraction. So, usually here the frontalis muscle is involved. Okay, so this is very simple thing to understand. So, just remember from this, you need to identify this eye signs and need to know what is most common, what are the different types of eye signs, and what is specific for Graves' disease, which is basically infiltrative eye signs, that is Mebius eye sign. So this was a question on thyroid eye signs, very important from the exam point of view. Now let's look at this question. True statement about solitary thyroid nodule in a 50-year-old male. So they've given a lot of options. CT better than MRI for diagnosis of solitary thyroid nodule, more risk of malignancy in men, no increased risk of malignancy, ultrasound screening is sufficient. So what is the true statement in this question? So remember, in male gender, risk of malignancy is higher. Thyroid nodules, again, that is also one of the previous year questions. We'll be discussing that. So thyroid nodules are more common in female. Okay, one of the reasons we'll be talking about it. Or autoimmune diseases are also more common. So thyroid disease in general is more common in female. However, in a male patient, the malignancy risk is always higher. All right. So let's look at some of the features that have a higher risk of malignancy. This is again a reference from Sabiston. So remember both extremes of age. So Sabiston says age younger than 20 years. However, just remember the highest risk of malignancy is less than 10-year population. So pediatric population, again, any patient with in the pediatric age group who presents with a thyroid nodule has a higher risk of malignancy as compared to an adult population. So less than 10 years or less than 20 years as per Sabiston, higher risk of malignancy. Older age group, again, more than 70 years is also going to be a higher risk of malignancy. Very, very important is that males who have thyroid nodules have a higher risk of malignancy. Again, nodules where patients are symptomatic, they present with compressive symptoms, either they have voice change or they have breathlessness or they have stridor or difficulty in swallowing. All these patients are going to be higher risk of malignancy. Presence of a hard thyroid nodule, again, not always a risk factor for malignancy. Sometimes you can get hard thyroid nodules also in calcified, long-standing calcified thyroid nodules can also feel hard. However, index of suspicion is higher if the nodule is hard, and also fixity. So hard and fixed. Fixity of the thyroid swelling is also a risk factor for malignancy. Again, large nodules, not again relatively higher risk of malignancy. Presence of cervical lymphadenopathy definitely indicates a malignant process. Previous radiation or previous family history, again, neck radiation is a risk factor for malignancy, especially in the younger age group. The younger age group, especially, you have a increased incidence of radiation induced thyroid cancers. Now, why that occurs? Basically, the thyroid gland is very superficial. It is highly susceptible to radiation damage. One is because of its superficial location. Second thing is because there is a high presence of peroxidase enzyme. Thyroid peroxidase enzyme, it is involved in the thyroid hormone synthesis. So, because of the presence of peroxidase enzymes and other enzymes like deox enzymes, there is a increased presence of reactive oxygen species that can be generated in the thyroid. So basically, your free radical damage and DNA damage occurs more commonly in the thyroid gland, and also it is located very superficially in the neck, in the exposed part of the neck. So again, radiation dose is higher. So especially in young children, radiation-induced cancers are more high because there is a latency period. So usually, thyroid cancers occur after 15 to 20 years after radiation exposure. So this is a important concept to understand. So these are the risk factors for malignancy in a thyroid cancer. Okay. Now let's look at this question. Flap with the least complication rate in breast reconstruction. Now let's look at the options that are given here. Again, this may be some overlap with what other people may have discussed. So you have a deep inferior epigastric perforator flap, you have a tram flap, a muscle sparing tram flap, or a superficial inferior epigastric artery perforator. So remember, the answer here is a superficial inferior epigastric artery perforator. Now there are reasons why we are going with this answer. Now this is straight away from Sabiston. So you can see these three different types of abdominal flaps. So you can see the deep inferior epigastric artery perforator. Again, here these perforators are coming from within the rectus abdominis muscle. These perforators coming from deep within the rectus abdominis muscle. So usually it requires a dissection within the intramuscular plane. So again, there is a higher risk of hernia and other complications. So muscle sparing tram is also one of the options that which is better than a tram flap. You are only going to take a small island of muscle along with this blood, along with the perforator supply. You all know the zone 1, zone 2, zone 3, zone 4 concept. So we don't remove the entire tram. We only take a small bit of tram along with the overlying soft tissue, which is well vascularized. Now the other thing is a superficial inferior epigastric. The superficial inferior epigastric, the advantage is that it is superficial in the fascia. It does not arise from within the intramuscular plane. So the advantage is that in these patients, you will not require much of muscular dissection. So all these other complications are reduced. So basically, the muscle sparing tram was done to reduce from the tram. It is different because it reduces the donor side morbidity. Here only the muscle around the perforator is harvested. Rest of the rectus abdominis muscle is left. Rectus fascia is also left intact. So here that's why the morbidity is lesser. Now, abdominal flaps, again, other perforator flaps can be done. So deep inferior epigastric perforator flap can be used. Again, here muscle in the fascia sparing harvest. So you preserve the innervation, but however still you may require to dissect deeper to the muscle. Whereas a superficial inferior epigastric flap, basically here the advantage is that the flap harvest is easier. So you don't have to violate the rectus sheath. You don't have to go into the intramuscular plane to dissect the perforators out. Here it is all in the superficial plane. And here, so the risk of abdominal wall weakening and hernia is lesser. But the disadvantage of using a superficial inferior epigastric flap is that they are very delicate vessels. So sometimes they are prone to either damage or they may be prone to vasospasm during dissection. So this may be a issue while harvesting these flaps. Let's look at the next question. So a lot of questions last year were asked on hyperparathyroidism, clinical scenarios, imaging. So let's look at this question here. So features of hyperthyroidism have been given. This is a young patient. What would be the next line of management? So what are the features of hyperparathyroidism? Now remember, there are two different forms of presentation. So you have an asymptomatic form of presentation and you have a symptomatic form of presentation. Now asymptomatic form is more common in the West, more common in Western countries. However, in India nowadays, asymptomatic hyperparathyroidism is increasing because more and more people are aware. There are a lot of general health checkups and calcium investigations that are being done. Calcium investigations have become widely available. Whereas traditionally in India, symptomatic hyperparathyroidism has been very, very common, and usually patients present with severe disease. So this is the difference between the disease pattern in India versus the West. So these symptomatic patients who present with hyperparathyroidism may have different manifestations. So we all know this stones, bones, groans, psychic moans, fatigue overtones. We all know that mnemonic. So patients will present with either bone disease, they may present with renal manifestations, they may present with abdominal manifestations, they may present with neuromuscular manifestations, and they may be effects on the central nervous system. So bone manifestations, you can have bony swelling, you can have osteoporosis, there is demineralization of the bone, patients may have pathological fracture, severe bone disease, they may even have what is known as a multiple brown tumors may also be there. Renal manifestations, you can have medullary nephrocalcinosis, you can have nephrolithiasis, urolithiasis. So these are some of the renal manifestations. Abdominal manifestations include increased incidence of pancreatitis, increased acid production because of the high calcium levels, so that can result in dyspepsia. Neuromuscular patients may present with proximal muscle weakness, difficulty in gait. All these are neuromuscular manifestations. And of course, you have CNS manifestations such as irritability, reduced memory, and a lot of depression and poor quality of life. So these are the different symptoms that a patient with hyperparathyroidism can present. So remember, you may not be given a question directly like this. You may be given a clinical scenario. You may be given some biochemical investigations also, and then they may twist these kind of clinical scenarios to ask you what is the next line of investigation. So what is the next line of investigation in this patient? So they have given us the options of an FDG PET CT. They've given an ultrasound neck, X-ray bilateral radiation spine, and a CECT of the head and neck. So what is the next line of investigation? The correct answer is ultrasound of the neck. Now remember, hyperparathyroidism is a biochemical diagnosis. So the diagnosis is biochemical. However, after doing a biochemical diagnosis, we do something known as a localization. So localization requires multiple investigations. Now when we do localization for hyperparathyroidism, usually we have to do an anatomical localization, and we do what is known as a functional localization. This is a very important concept to understand in endocrine surgery. So we always do a functional imaging. So an anatomical imaging, the most common imaging that we use is an ultrasound of the neck. It is relatively cheap, it is widely available, and it is since the thyroid and the parathyroid are relatively superficial structures, it is easy to recognize a parathyroid gland. Now, what about functional imaging? So functional imaging is when we do a technetium 99 sestamibi. So sestamibi is a radio pharmaceutical that is tagged to technetium. Here, basically because of increased mitochondria, there is increased mitochondria in the oxyphil cells, and this increased mitochondria shows increased activity in the sesame B scan. Now, you can see here ultrasound is always the initial imaging modality because it is very cheap, it is easily available, and can be performed even by the operating surgeons themselves. So most of us endocrine surgeons are well trained in ultrasound. We do ultrasounds ourselves to recognize the parathyroid. Sometimes we are able to recognize parathyroid even better than a well-trained radiologist because we see them more commonly. So remember, how does a parathyroid adenoma or an abnormal, usually a normal parathyroid is not visible on the ultrasound, whereas an abnormal parathyroid basically is a hypoechoic. So remember, hypoechoic as in the thyroid is more hyperechoic as compared to a parathyroid adenoma. So you get a hypoechoic oval or a round mass, and usually the capsule of the parathyroid gland is hypercircular. So basically you have a hypoechoic adenoma, but a hyperechoic rim, or a hyperechoic or a echogenic capsule around it. And usually a parathyroid adenoma also has something known as a polar feeding vessel. So the parathyroid adenoma usually has a rim of vascularity around it. This will be hypo, the capsule is hyper, and usually you have vascularity that is surrounding the rim, and at one point there is these vessels have an end-on appearance, so they appear like a dot, so that is known as a polar feeding vessel. So at one pole there is a feeding vessel with an end-on appearance, so that is known as a polar feeding vessel sign. This is a pathognomonic sign for a parathyroid gland. Remember, ultrasound is the first investigation that we do. Of course, if SMV scintigraphy was here in this question, that makes it complicated. But again, next line of investigation, because there is no system EV here, you should go with ultrasound of the neck. Now, what about CT of the head and neck? Some people may ask, why not that as the option? So remember, we also use other investigations. So when we look at other anatomical scans that can be done, or a combination of anatomical functional, sometimes we can even do an MRI of the neck. That is also has some good sensitivity and specificity. We can also do something known as a 4-dimensional CT scan. A 4-dimensional CT scan is basically a triple phase CT scan, but also use the fourth dimension is time. So we use basically differential. So there is differential enhancement. So rapid enhancement and washout is what we look for in a parathyroid adenoma on a 4D CT. So, however, remember 4D CTs are very rarely done as the first line of management, first line of evaluation. So, 4D CT is usually reserved for recurrent hyperparathyroidism or reoperative patients who have had a failed focus parathyroidectomy. You've done a parathyroid surgery, you've removed a parathyroid, but you're unable to get biochemical care. In those patients, it's better to use a 4D CT. Right? So ultrasound neck relatively cheaper. However, the problem with doing an ultrasound neck is sometimes lymph nodes may be present, thyroid nodules may be present. So all these structures sometimes may resemble a thyroid adenoma on the ultrasound neck. So this reduces the sensitivity specificity of ultrasound of the neck. And other thing is, because you're scanning only the neck and the cervical structures, again you cannot see ectopic parathyroid. So especially parathyroid glands that are sitting in the mediastinum, you may miss them out on an ultrasound of the neck. So functional imaging like sestamibi, it's easier to pick up these ectopic parathyroids, especially if they are sitting in the Can you hear me now? I hope you can hear me. Can somebody confirm if you can hear me? Yeah. So for an you guys can hear me? Yes, great. Thank you. Thank you so much for that confirmation. I'm sorry about that. Yeah. So remember, when you do a 4D CT, the advantage that it gives again is it gives you good anatomical imaging also. Now, when you do a sestamibi, you can just about make out that there is uptake in the upper part of the neck or the lower part of the neck. You are not able to localize it very well like a CT scan. So that is why it's important to do a 4D CT. Again, MRI also gives you good soft tissue differentiation, but cheaper, easier, can be done by the surgeon is an ultrasound of the neck. So that is the first investigation that you would do in localizing a parathyroid adenoma. In the same question, if they were to ask you what is the first functional imaging that you would do, you should go with a sestamibi scan. All right. So remember anatomical and functional imaging modalities. Okay. So let's look at this next question. 17-year-old boy with elevated serum calcium, elevated serum PTH. Patient has a fracture of the neck of femur, and ultrasound of the neck was done. Ultrasound of the neck was normal, and sestamibi SPECT CT was done, which showed an uptake in the posterior mediastinum more onto the left side. So what could be the
possibility. Again, you may get a picture of a system EB. You may be given a picture of a CT scan with a SPECT CT, system EB SPECT CT. So what do you mean by SPECT CT? SPECT CT is basically when you combine the system EB along with a limited cross section CT. So these are the scenario that is given here. So important thing, what could be the possible diagnosis here? So you have given options like parathyroid carcinoma, superior parathyroid adenoma, PTHRP secreting lung tumor, or an intrathymic parathyroid adenoma. So these are the options that have been given to us. Now remember, look at the question very clearly, and we have to answer this question. Now the clue in this question is posterior mediastinum. So that is the important catch phrase in this question. So obviously we know this, the diagnosis for this patient is primary hyperparathyroidism. That is obvious. Now primary hyperthyroidism, the most common cause of primary hyperparathyroidism is a parathyroid adenoma. The second most common is a parathyroid hyperplasia, and the least common is a parathyroid carcinoma. All right, so most probably this is a parathyroid adenoma. So because the location of the given abnormal gland here is posterior mediastinum, the answer is a superior parathyroid adenoma. So now I'll explain to you why. So remember, when we talk about superior and inferior parathyroids, now which of the superior and inferior are more commonly ectopic? So most common ectopic, these are all important MCQs. So most common ectopic parathyroid gland is the inferior parathyroid gland. We all know that. So the inferior parathyroid gland, or the third pharyngeal pouch derivative, has a longer course of migration. So that is why it is the most common ectopic parathyroid gland. Now again, remember when we talk about ectopia, there are two types of ectopia. Again, this is a little advanced concept. I'm just telling you, congenital and acquired. So when we talk about congenital is what we usually say, because the embryological descent is longer for an inferior parathyroid gland, it is known as a congenital ectopia. So most common ectopic congenital ectopia is inferior parathyroid gland. Now acquired ectopia is basically an abnormal parathyroid gland, enlarged parathyroid gland, because of either the large size, because of the space in the neck, gravity, because of swallowing mechanism, the movement with swallowing. So all these kind of forces can push a parathyroid gland. Enlarged abnormal pathological parathyroid gland can move downwards. That is known as acquired parathyroid ectopia. So this is more common in a superior parathyroid gland because of the presence of more space as compared to the inferior parathyroid gland. All right, so congenital ectopia, inferior parathyroid gland, nothing is mentioned, only most common ectopic parathyroid gland, then again inferior parathyroid gland. If they mention specifically acquired parathyroid ectopia, then superior parathyroid gland is the answer. So remember, superior parathyroid gland, usually they pass along the tracheoesophageal groove. They usually have a retropharyngeal or a retroesophageal path, and they go to the posterior mediastinum. So this is very important. So whenever you find an abnormal gland in the posterior mediastinum, then they are going to be a superior parathyroid gland derivative. Inferior parathyroid gland is closely associated with the thymus. Basically, the ventral part becomes the thymus and the dorsal part becomes the inferior parathyroid gland. So because of that reason, it travels along with the thymus. Now, as we all know, the thymus crosses from the neck into the mediastinum in the anterior, anterior and the superior mediastinum. So basically, the most common location for a ectopic inferior parathyroid gland is usually in the thymus or in the anterior or superior mediastinum. So this is a very important concept that you need to understand. All right. So most common location is within the thymus. Most common location for the superior parathyroid gland is usually where the inferior thyroid artery crosses the recurrent laryngeal nerve. So usually 1 centimeter cephalad to it, 1 centimeter superior or cephalad to the crossing of the IT and recurrent nerve. 80% of the times you will find a superior parathyroid gland there. So this is just a bit of applied embryology of the parathyroid gland. Very important question. So a lot of questions have been asked this time with multiple endocrine neoplasia. So timing of prophylactic thyroidectomy in men 2A. Again, this can be directly asked. You can have a clinical scenario. They can give you components of men 2A. So when we talk about men syndrome, we have a men 1 and a men 2. So we are going to be talking about men 2. So men 2 has a men 2A and men 2 has a men 2B. So men 2A has these components. Remember, it has medullary thyroid cancer, pheochromocytoma, and it has primary hyperparathyroidism. These are the MEN2A features. MEN2B features will usually have the first two components, that is MTC and pheochromocytoma, and then you will have lot of non-endocrine manifestations. You may have ganglioneuromas, which may there be in the oral cavity, intestinal ganglioneuromas. You can have skeletal changes like marfanoid habitus, chest wall deformities. You can have corneal nerve thickening. So a lot of non-endocrine manifestations in a MEN2B disease. All right. So here we are asking us about MEN2A in particular, and they're asking about prophylactic thyroidectomy. Now remember, let me just tell me about MEN1 also. So MEN1 has different components. So MEN1 usually has a primary hyperparathyroidism, which is most common. Then you have gastroenteric, pancreatic, neuroendocrine tumors, and least common is a pituitary adenomas. Usually they are prolactinomas. So this is MEN1. So remember, MEN2 has a good, this is a very important concept to understand. So MEN2 has a genotype-phenotype correlation. So that is why you can do prophylactic surgery in MEN2 disease, either MEN2A or MEN2B. Now MEN1, there is no genotype phenotype correlation. So here you cannot do prophylactic surgery. All right. It's a very important concept to understand. Same scenario, you may be given a MEN1 scenario, you can be asked timing of prophylactic thyroidectomy. There it is not done. Whereas in a MEN2A syndrome, usually we do a prophylactic surgery less than 5 years. So the options here again, just try to remember the concept. So the options may be different. The actual options may have been different, but just remember the concept. Usually in a MEN2 disease, we operate less than 5 years. MEN2A disease, we operate less than 5 years. Now MEN2B is highly aggressive. So here we usually operate within the first year of life. Usually even in the neonatal period, they are operated on. So within the first year of life, we operate on MEN2B patients. So very important to understand this genotype phenotype correlation. So again, when we classify these, so this is what is known as codon directed surgery. So codon directed surgery is where you're going to give prophylactic surgery to the patient depending on the genetic mutation that they have been found. So we have this highest category, which is 918 mutation. This is basically your MEN2B. So usually in MEN2B, they're very aggressive. So we operate within the first year of life, as early as possible or within the first year of life. We don't necessarily have to wait for a elevated calcitonin level. Usually we operate on these patients within the first year of life. Now, what about the next category, which is high category? So high category is usually a 634 mutation. This is the most common mutation in medullary thyroid cancer. And you can get an 883 mutation. Now, 883 mutation also is MEN2B, whereas 634 is MEN2A. All right, so MEN2A, 634, most common mutation in MTC. So here, usually we operate within 5 years of age. However, sometimes if you have a lower risk mutation, like all these other mutations come under moderate risk, in these patients, you can operate even in adulthood. You can operate whenever the calcitonin level gets elevated. So we have to follow up the calcitonin level. Whereas in a high risk mutation, usually we try to operate within 5 years of age. So this is codon directed surgery in medullary thyroid cancer. This is for MEN2 syndrome. Okay, which of the following statements are true regarding pheochromocytoma? SDHB mutation is not seen. They are more malignant in MEN syndrome. They secrete calcitonin and PTH related peptide, or CT is better than MRI. Now this is a little complicated question, so let's go option by option. So the answer here is they can secrete calcitonin and PTH related peptide. So remember, there are a lot of hereditary pheochromocytoma syndromes or pheochromocytoma paraganglioma syndrome. So the most common is PHL. This is very important. So the most common germline mutation. So a pheochromocytoma may have a germline or a somatic mutation. So the most common germline mutation is VHL syndrome. This is chromosome 3. MEN2 is the second most common. Neurofibroma NF1 is the third most common, and of course you can get SDH mutations also. Now remember, when you talk about NF1, they are the most common somatic mutations for pheochromocytoma. Okay, very important concept to understand. So most common somatic is NF1, most common germline is VHL mutations. Now remember, in MEN2 disease, as I already mentioned, it is MTC, pheochromocytoma, and primary hyperparathyroidism. So MTC occurs in almost 95 to 100% of patients. 40 to 50% will have pheochromocytoma, and about 20 to 30% will develop primary hyperparathyroidism. Remember, in MEN2 disease, the pheochromocytoma is almost always benign. So similar to medullary thyroid cancer, now medullary thyroid cancer has a pre-malignant phase. There's a C-cell hyperplasia in MEN2 disease. So similarly, even in pheochromocytoma, you can get an adrenal medullary hyperplasia, and then they eventually develop a pheochromocytoma. So they are almost always benign. Very rarely they are malignant in MEN2 syndrome. And again, when we compared head-to-head CT with MRI, CT is something that we most commonly use for evaluation of an adrenal mass. However, MRI is slightly more sensitive. It can pick up even smaller lesions. Sometimes we also use something known as chemical shift imaging. So we are able to differentiate between a lipid rich and a lipid poor. So this is what we use an MRI for. So you can do chemical shift imaging to differentiate between lipid poor versus a lipid rich adenoma. So they are slightly more sensitive. However, CT offers a better anatomical delineation. So the answer here is that they do secrete calcium and PTHRP. Now remember, pheochromocytoma not only secretes, what are the things that pheochromocytoma can secrete? Usually the most common catecholamine that a pheochromocytoma secretes is norepinephrine. So this is most common catecholamine that is secreted by a pheochromocytoma. What are the other catecholamines that can be secreted? You can have epinephrine that can be secreted, or you can even have dopamine secreting tumors. Now remember, the pheochromocytomas are slightly different from paragangliomas. So basically, they don't have the paragangliomas, which are extraadrenal, they lack this enzyme called phenyl N-methyl transferase. So because this enzyme is not present in the extraadrenal paragangliomas, the conversion from norepinephrine to epinephrine. So this step is blocked. So basically remember, in an extraadrenal pheochromocytoma, you will never have epinephrine. They are all norepinephrine secreting tumors. Dopamine can be secreted in some tumors, especially in children. They are more dopamine secreting tumors, and usually these dopamine secreting tumors, there is no hypotension. So they tend to be normotensive, whereas norepinephrine and epinephrine secreting tumors, they are usually hypertensive. So these are few interesting things that you need to know about pheochromocytoma. Okay, we again slightly touched upon this in the previous question. So goiter in female more than male. What is the reason? So genetic TSH increase along with prolactin, estrogen receptors in the thyroid. Again, this is a slightly advanced concept. So remember, the answer is there are enhanced estrogen receptors in the thyroid. So that is why thyroid diseases are more prevalent in the women. All right, especially in the reproductive age group. One is because of the impact of estrogen. Other thing is autoimmune disease itself is more common in women. So there are indirect and direct effects on thyroid. So you can, they are basically genomic mechanisms and non-genomic mechanisms also. So just remember the increased estrogen receptors. Like a breast cancer, you can have increased estrogen receptors in the thyroid also, and that is why you have more common thyroid diseases among women. Okay. Let's look at this. Carcinoma of breast in pregnant female different from normal female. Which of the following is false? No need of mammography in a pregnant female. Stage for stage worse prognosis as compared to a non-pregnant female. Neoadjuvant treatment can be given in second and third trimester. Dilated duct can be confused for lobar lesion. So again, this is they are talking about pregnancy associated breast cancer. Now remember, usually in a pregnancy associated breast cancer, the definition is either the cancer arising during pregnancy or within 1 year postpartum. So this is how we define a pregnancy associated breast cancer. So remember, usually in a pregnant female, we don't do a mammography. Mammography is generally contraindicated in a pregnant female. Very rarely, if you really require a mammography, then you'll have to do a abdominal shielding before you do a mammography. But usually we avoid a mammography in a pregnant female. and neoadjuvant treatment can be given in second and third trimester. So this is a correct statement. So usually, pregnant female in first trimester, we don't give chemo. We try and operate the patient in the second and the third trimester. But however, in the second and the third trimester, if there is an indication for chemotherapy, this is the right time to give chemotherapy. So usually we time the chemotherapy in the second or third trimester. Towards the end of the third trimester, we try to stop the chemo, allow the patient to deliver, and then following that, either we follow up. Usually, we go ahead with surgery after the delivery of the patient. So remember, chemotherapy is appropriate in the only in the second and third trimester of the pregnancy. First trimester, there is no role for chemotherapy because of the teratogenic effect of the drugs. Of course, in these patients, you can have, because of the hormonal changes, an exaggerated effect of hormonal changes in pregnancy, you can have dilated ducts that can be confused for lobar lesions. So the correct answer here is stage for stage, worst prognosis as compared to non-pregnant female. Correct, and since this statement is false. So remember, the pregnancy associated breast cancer is considered a little more aggressive disease, but when you look at stage by stage or stage for stage comparison, the outcome is the same as a non-pregnant female. Just that these patients tend to present more older in age, and they are more hormone positive and HER2 negative. And so the stage for stage prognosis when you compare a pregnant and a non-pregnant female is the same. The risk factors for the breast cancer in a pregnant versus non-pregnant female also is the same. So this is the false statement. It is not worse as compared to a non-pregnant female. Okay, let's go on to the next question. What is the most common complication of total thyroidectomy? Recurrent laryngeal nerve palsy, hypocalcemia, hemorrhage, or serum? So this is a very straightforward question. The most common complication of total thyroidectomy is hypocalcemia. Now, why do we get hypocalcemia? Hypocalcemia basically occurs because of hyperparathyroidism. So what is the reason why we get hyperparathyroidism in a patient who's undergone a total thyroidectomy? One is you can have an inadvertent parathyroidectomy. So while you are doing the thyroid surgery, you can inadvertently, the parathyroid is located very close to the capsule of the thyroid gland. So while you are trying to excise the thyroid gland, you may accidentally excise the parathyroid gland also along with the thyroid. So there is an inadvertent parathyroidectomy can cause hypoparathyroidism. Other thing is vascular damage. Sometimes you may visualize the parathyroid, you may preserve it, but you may devascularize it. Now, what is the vascular supply of the parathyroid gland? Remember, predominant vascular supply. In 80%, the parathyroid gland is supplied by the inferior thyroid artery. In 20%, you can get superior thyroid artery. Very rarely, you can get direct branches from the aorta. However, usually 80% of the time, inferior thyroid artery supplies both the superior parathyroid gland and the inferior parathyroid gland. Usually, when you have a thyroid lobe like that, and you have the inferior thyroid artery coming, this is the lateral view. You may get the parathyroid gland here. So usually the inferior parathyroid artery gives off a branch to the parathyroid gland, and then it proceeds to enter into the thyroid parenchyma. So when we do a total thyroidectomy, if we are going to ligate the inferior thyroid artery here, then the supply to the parathyroid gland will be lost, and here you will have hypoparathyroidism. Whereas we do something called a subcapsular dissection. So these are all important terms. We do something called a subcapsular dissection. So here what we do is we dissect between the true and false capsule of the thyroid gland. Okay, there's a loose capsule which is known as the false capsule, and the true capsule is densely adherent to the thyroid surface. So we dissect between these two, and the ligation of the inferior thyroid artery is done close to the thyroid gland, in between these two true and false capsule, so that we are able to preserve the supply to the parathyroid gland and there is no hypoparathyroidism. So hypoparathyroidism is the most common complication. Temporary hypocalcemia, 15%. There are some centers even 20 to 30%. There are some articles that are saying. However, permanent hypocalcemia, usually that is the previous definition for permanent hypocalcemia was 6 months. So hypoparathyroidism that is lasting more than 6 months, this occurs only about less than 3% of patients. However, the current definition, the latest guidelines, the definition of permanent hypocalcemia has become 1 year. So more than 1 year. So that is a recent change, 2023 guidelines. It is saying that more than 1 year is permanent hypoparathyroidism. Okay. Clinical image, identify the correct diagnosis, MEN 2A, MEN 1, MEN 2B, MEN 4. We again discussed this. So these, you can see these nodular lesions on the tongue. So this is what is known as ganglioneuromas or neuromas. So these are neuromas that are found in the tongue. They may be found in the oral cavity. They may be found in the other mucosal areas. You can find it in the gut as well. So this is characteristic of a MEN 2B syndrome. So let's look at this quickly. Look at this table. So again, as I told you, both MEN 2 and MEN 2B will have MTC and Pheochromocytoma. MEN 2A will have a primary hyperparathyroidism. However, MEN 2B does not have any primary hyperparathyroidism. Instead of that, you get these mucocutaneous ganglioneuromas, you can get marfanoid habitus. So this is how MEN 2A and MEN 2B will differ. Alright, so MEN 2B is basically 918 mutation, whereas MEN 2A most common is a 634 mutation. So this is what you need to know from this table. So picture of a MEN 2B mucosal neuroma has been given to you. Very easy to identify this. Okay, this is a slightly difficult question. So dye that is least suitable for sentinel lymph node biopsy. So they've given us options: isosulfan blue, indocyanine green, methylene blue, colloid sulfur. Now remember, all these 4 drugs, all these 4 dyes have been described for use in sentinel lymph node biopsy. So all of them we use for sentinel lymph node biopsy. But the question here is, what is least suitable? So I have tried to look up some literature for you. The answer here is methylene blue. Now remember, methylene blue is something that we commonly use for sentinel lymph node biopsy. However, they're not asking what is the least used, what is least suitable for SLM. So I have my reasons for this. I'm going to tell you that. So remember, isosulfan blue, these are basically isosulfan blue and methylene blue belong to these group of substances known as vital dyes. Here basically the isosulfan blue specifically is taken by the lymphatics because it is conjugated to albumin and it is retained within the lymphatics and the sentinel lymph node. So basically the extra lymphatic tissue, there is less amount of leak. Now methylene blue, again we use it. However, the uptake by lymphatics is poorer than isosulfan blue. However, it is very cheap. So methylene blue is cheap. It is widely available. So this is what actually we commonly use. This is very most commonly used dye is a methylene blue dye. ICG is a recent dye that has been approved. So this is based on fluorescence imaging. So here again, this gives you a better identification as compared to a methylene blue. And radiocolloid is basically isotope based imaging. So we usually use technetium 99 colloid sulfur. This is what we use for radiocolloid imaging. So remember, when we do a sentinel lymph node biopsy, now the current to increase the sensitivity specificity, we usually use a combination of dyes. So we can use the methylene blue along with the radiocolloid or methylene blue along with ICG. That basically increases the sensitivity specificity. It reduces the false negative rate and increases the identification rate in a sentinel lymph node biopsy. So if you look at this picture quickly to compare ICG with blue dye, definitely ICG is significantly better identification rate as compared to blue dye. If we compare ICG along with radiocolloid, it's not significantly different, so it is comparable. And when you compare ICG with dual dye, again ICG fares better. So ICG definitely also has a good. It's a recent molecule that is used for fluorescence imaging in sentinel lymph node biopsy for breast cancer. Okay, so this clinical scenario: 45-year-old lady with recurrent urinary stones, UTI, increased PTH, increased calcium, normal phosphorus, normal creatinine and vitamin D. What is the diagnosis? Primary hyperparathyroidism, secondary hyperparathyroidism, recurrent hyperparathyroidism, or tertiary hyperparathyroidism. So we are going to look at how do we do a biochemical diagnosis of hyperparathyroidism. So remember, hyperparathyroidism, basically you have increased inappropriately elevated PTH levels. So usually in the setting of hypercalcemia, your PTH level should be low. But increased PTH levels in the setting of increased calcium levels, and the phosphorus usually is normal or low. All right. And an important thing is you must rule out secondary causes of hyperparathyroidism. So usually what are the secondary causes of hyperparathyroidism? One of them is chronic kidney disease. So you can have an elevated creatinine. And other thing is vitamin D deficiency. So vitamin D deficiency again. So when you have vitamin D deficiency, that causes a secondary increase in PTH. So these are causes of secondary hyperparathyroidism. So if you look at this scenario, you have a normal creatinine, normal vitamin D. So your secondary hyperparathyroidism is ruled out. Tertiary hyperparathyroidism is basically in the setting of secondary hyperparathyroidism. Following a renal transplant, the gland becomes autonomically functioning. That is known as tertiary hyperparathyroidism. So this also is not the answer. There is no scenario of dialysis, CKD, or transplant, the normal creatinine levels. And of course, recurrent hyperparathyroidism, usually you get in a young patient with MEN1 disease. They are prone for recurrent hyperparathyroidism because there's a high incidence of ectopic gland and supernumerary gland. That's why you get recurrent hyperparathyroidism. So the correct answer here is primary hyperparathyroidism. So very important table from Schwartz. You can look at it: increased calcium, increased PTH levels, decreased or low normal phosphorus, and of course, along with this, you can see that the vitamin D has to be normal. All right. So these are the features of a primary hyperparathyroidism. Okay, elderly female with fatigue, bone pain, elevated calcium levels, 12 mg/%. Imaging was followed by neck exploration. Intra photo shown below. What is the diagnosis? So we look here. This is the thyroid. This is the thyroid, and you can see this abnormal gland here. So in this clinical image, you can see only one gland that is seen, that is enlarged. So here the answer will be a parathyroid adenoma. Now suppose some people have told me that the clinical picture showed multiple parathyroids enlarged. So if you get a picture like that with multiple parathyroids being enlarged, then the answer will be a parathyroid hyperplasia. This is not a thyroid nodule. So it's a little difficult question. You have to look at the clinical photo properly. So remember, I have already told you this. Parathyroid adenoma is the most common. So solitary parathyroid adenoma, 85 to 90% of cause for primary hyperparathyroidism. Hyperplasia occurs in about 10 to 15%. Again, it may be secondary. It may be it may be a genetic disease like a Men's syndrome. And of course, parathyroid carcinoma is very rare. It occurs only in 1% of patients. Usually, you will have very high PTH levels, severe hypercalcemia, and you may have in 50%, you can have palpable parathyroid gland. Okay. Unilateral neck swelling which moves on deglutition but not on protrusion of the tongue. Opposite lobe is not palpable. Which of the following favors diagnosis of solitary thyroid nodule? It is a dominant swelling with other nodules. Single swelling is palpable. Remainder of the gland is not palpable. Whole gland is palpable and enlarged, or it is a metastatic lymph node. This is a very straightforward clinical question. Nothing much to think about. This is a single swelling palpable. Remainder of the gland is not palpable. So when you talk about diagnosis of thyroid gland, there are multiple diagnoses. So these are anatomical diagnosis of the thyroid gland. So when we talk about a solitary thyroid nodule, we draw a picture of the thyroid. So a solitary thyroid nodule is a nodule in one part of the lobe and the rest of the gland is not palpable. So this basically becomes a solitary thyroid nodule. Now what about a multinodular goiter? Is basically there are multiple nodules in both lobes of the thyroid gland, and that is known as a multinodular goiter. A dominant nodule of a multinodular goiter is basically you have one large nodule which is palpable. The opposite lobe is also palpable because there are small nodules, but you don't have any discrete multiple nodules in the opposite lobe. So basically, you have only one nodule that is palpable in the ipsilateral lobe, whereas the contralateral lobe is palpable because of some pathology. So that is a dominant nodule of a multinodular goiter. Diffuse goiter, of course, we know Graves' disease, physiological goiter, diffusely palpable. Both lobes are palpable. It's like a butterfly-shaped gland that is known as a diffuse goiter. It's a very straightforward question, but a very basic principle that they have asked. Okay. Patient on carbimazole develops sore throat. What is the next line of evaluation? So they have given you options: ultrasound of the neck, WBC counts, thyroid biopsy, or a thyroid antibody level. So this is basically talking about a patient who's on antithyroid drugs, is an antithyroid drug, and developed sore throat. So the correct answer here is you would do a WBC count. So remember, it is a very important and it's a rare side effect, but it's very important and life-threatening side effect. Usually you get agranulocytosis. So this is a rare side effect that can occur with antithyroid imidazoles that are antithyroid medication. Of course, there are other complications like skin rash, fever, etc. So any patient who you're starting on an antithyroid medication, especially carbimazole, you should always give them the warning that if they develop recurrent fever, if they develop sore throat, then in that situation, they have to stop the drug and they have to do a WBC count and come back to you for further management. Usually it is managed conservatively. You stop the drug, the counts will improve. You can give GCSF injections, so that can also improve the count. Sometimes you can cover with an antibiotic. However, it's conservatively managed. So if you look at all the side effects of antithyroid drugs, remember most common are minor reactions. These are most common. You can develop fever, rash, allergy, etc. Arthritis like syndrome. Now, agranulocytosis, these are immune-mediated complications. Now, remember, agranulocytosis in antithyroid drugs are idiosyncratic. That means you cannot predict when the agranulocytosis happen. Usually, it occurs within 3 months, so it's an early complication. But however, you cannot predict it. So usually, we don't do a complete blood count on a normal basis regularly to screen for this. It can occur with anybody. It can occur at any dose at any time. Usually, it is symptom directed. That's why if you have a patient who has sore throat, fever, symptoms, then you go ahead and do a CBC for these patients. Hepatotoxicity also is an important side effect, more common with propylthiouracil. And remember, with propylthiouracil, you can get severe fulminant hepatic failure, more common in children. That's why in children, even though in pregnancy we prefer to give propylthiouracil, it's better to switch over to methimazole. So usually, in pregnancy, when we treat Graves' disease, in the first trimester during the period of organogenesis, we give methimazole so that in the first trimester, usually we give a propylthiouracil so that the methimazole-induced embryopathy, that is your choanal atresia, aplasia cutis, so all this methimazole-induced embryopathy does not occur. So that is why in the first trimester during organogenesis, we give propylthiouracil. However, later stage, it may cause hepatic fulminant hepatic necrosis. So we switch over, second, third trimester, we switch over to methimazole. Methimazole also can cause hepatotoxicity that is more cholestatic and reversible, and it is lesser in intensity. A delayed complication of antithyroid medication is presence of P-ANCA vasculitis. And of course, you can get other hematological abnormalities also. Okay. Rubens flap for breast reconstruction is based on deep inferior epigastric, hypogastric, deep circumflex iliac or pudendal artery. So again, this is a very fact-based question, a little bit on the difficult side. So remember, Rubens flap is basically based on the deep circumflex iliac artery. So the deep circumflex iliac artery usually arises just anterior to the anterior superior iliac spine. So just above the anterior superior iliac spine. So the deep circumflex iliac artery is lying here deep to the anterior superior iliac spine, and sorry, and so the deep circumflex iliac artery gives off perforators that come onto the skin. So usually at the area of the lateral flank, just above the ASIS, you can use tissue, soft tissue, along with soft tissue and fascia. You can use for reconstruction of the breast. This can be combined with a DIEP flap as well for bilateral breast reconstruction. So I think I've covered most of the important questions. A lot of questions from men, a lot of clinical scenarios, a lot of questions from parathyroid. So hopefully this session was useful for you. So I think focus on clinical scenarios, focus on image-based questions, and the tables from Sabiston and Schwartz are very important. Especially men's syndrome also, we got a lot of questions last year. So with that, I think we'll end today's session. All the best for your upcoming exams. I hope all of you will do well. Thank you.